So this is a cuffed trach. What that means is it has a cuff to hold it in place. There are cuffed and uncuffed trachs. All right. Thank you. All right. You guys remember this from the module?
Mm-hmm.
Neck plate, flange, hold it up against the skin. This is what I'm talking about. Sometimes these things will be sutured into place. Sometimes they won't be, okay? Well, lots of crusties and stuff start to develop around behind here. So that's why we use this gauze.
Oh, like a fresh piercing.
Yeah. And it just sits underneath there just like that, okay? That makes sense?
Mm-hmm.
Now, when this is brand new and fresh, we don't want to jack with it too much because we want them to clot. And so if you go in there and you're sucking out the clots over and over again, then they're going to continue to bleed. If anybody has an established trach and all of a sudden you see fresh red blood, then what are we going to do?
Call the healthcare provider.
Or call somebody. If we see, like, you know, like as bleeding goes, it should go from sanguineous to serosanguineous to serous. You see what I'm saying? If we ever go backwards and it goes back to sanguineous, then we call because that's a medical emergency, right? Okay. Up on the front, it'll have ID and OD, okay, down here. And it'll usually have a size. So this is a 6 cuff, okay? And this is ID is inner diameter and OD is outer diameter, okay? You don't normally need to know the ID and OD, but if somebody were to ask, this is where you would find it, okay? There are times where that might happen. But you do want to know the 6, okay? Because the inner cannulas will be kind of off to the side and you want to have a replacement. Can a patient ever rip this thing out?
Mm-hmm.
They can, you know, and if they ripped it out, would you want to just pick it up off the floor and be like, I got you, Miss Jones?
Hey, you know what?
Yeah.
Shouldn't have thrown it.
Shouldn't have done it, right? You'll be all right, you know?
Yeah.
Now, you want to have a replacement one kind of sitting off to the side, and you want to make sure it's the right size or smaller, because you're not going to put something bigger into a hole, right? Especially a hole that has had trauma now from getting ripped out.
Mhm.
Make sense? Okay. Sometimes you just don't have the right size, so you have to go with something smaller, okay, as an emergency. All right, this is the outer cannula. This is the inner cannula I was talking about. Now, we're gonna practice cleaning these and putting them in the bin and moving it, but again, look at this, big red letters. See what it says?
No.
Read it out for me.
Do not clean or reuse.
Okay, this is like 98, 99% of what you're gonna see. Please God, do not go and clean these things and be like, well, at Alvin Community College, they told me to clean and reuse. No, I told you to read. Reading is important, okay? All right, so I told you this one's cuffed, right? So it comes out, and she gave me the only kind of syringe that probably won't work. Failed. Tried to give me an oral syringe.
Just try to blow it with your mouth.
There's a valve.
Just blow.
Go ahead, try it. Thank you.
It's
It's completely
I lied.
sanitary.
They're all the
You
same.
keep giving me the oral syringes. Okay.
Are you wanting one that's like we would use
Lure
for like
A
the?
regular Lure Lock 10cc syringe.
Okay.
That's okay. All right. So this comes off, and this piece right here is called a pilot balloon. Okay. Now it's flat, which would tell me that the cuff is deflated. But if I were to put air into here with a Lure Lock syringe, you know, it would depress this valve, and I could push some air in, and this balloon would inflate, and this cuff would inflate. That's what holds it in place. Okay. Every now and again, somebody will cut these things. Okay. Also, you know, you might have an order to deflate the cuff for a few hours from time to time. All right. What I will tell you is that Respiratory Therapy checks the cuff pressure. They got a special syringe. They used to have a little machine, and then Jaco came through and said, "That's gross. You're taking it from patient to patient." And they were like, "Yeah." And they're like, "That's gross. Don't do that." So then somebody made a whole
AG
lot of
cuff?
money making a little bitty syringe that's got a pressure backflow. So anyway, they'll check to make sure that there's not
Like
too much
checking a
pressure
tire.
on the trachea. Yeah, yeah, just like checking a tire. Okay, it's green and red too. It's like good, bad. Okay, so this is the tracheostomy tube. This is the inner cannula. Okay, this is an obturator. So when you look on your checkout sheet, it's going to say that you got a replacement trach and that you got an obturator available. Does that make sense?
Yep.
Okay. What does this look like?
Mm.
No.
Oh.
Like a stylet, like the needle on the angiocatheter, right? It's the guide. Is there a hole in the end of that thing?
It's like a
No.
dinosaur.
Dirty mind. Okay, all right. So the way that this works is if the patient were to rip this out, right, and we want to put it back. This one's a little rigid, but if we want to make it really rigid, and the problem is look, see that? That's kind of sharp, right? So it could potentially tear up the airway as it's going in, and it can actually get clogged with tissue, which I've had that happen before. They're like, oh yeah, we replaced the trach, and I'm like, man, they're acting like they're plugged up. And we swapped the trach out, and sure enough, there's a whole bunch of lung tissue on this thing, or
Oh,
bronchial
wow.
tissue. Okay, but when we put this obturator in there, this isn't the right size, but see, it's nice and smooth now, right? And it acts as a guide. So if I were to push this down, I can get it into place. Does that make sense? Okay. I like to tell you guys stories so you remember, and I like to tell you stories that happened to me because they were bad luck, and if you learn, it won't happen to you, okay? I was on orientation. I'd been a nurse for like all of 2 months. Now I'm over here, and we had 4 rooms. It was like 5, 6, 7, and then like 8, right? So I'm in room 8, VRE, MRSA, all that good stuff, right? I'm gowned up, gloved up, doing my care. I look over. Mandy's patient is in room 5, fresh trach. He's restrained because that's what we did to everybody, and he's over here like, and he can't get it. And I'm like, I wonder where Mandy's at. She's probably hanging out, having her 2-hour coffee that she had every morning when she got there. And I was like, hey, Mandy. No Mandy. All right, no Mandy. Hey, don't do that, Mr. Jones. Don't do that, Mr. Jones. Well, anyway, about 30 minutes later, Mr. Jones is like, poof, rips it out, right? I'm like, oh my God, what do I do? So rip everything off. All right, let me go over here. All right, got this. I was like, okay, I need to put the obturator in there. Okay, cool, got it. All right, I take it and I shoved it down, and I was like, yes, I got it. You know, I had like trach ties. You know, you got to pull the ties, shove it into place. I'm like, I'm there. I'm looking at the guy, and he's like, I'm like, oh, what the hell? Breathe. Oh yeah. Oh God. All right. And so anyway, the obturator, you cannot breathe through hard plastic, okay? So obturator comes out, and then you put the inner cannula in, okay? And then it has 2 wings. They come in different kind of size, some twist, but this is probably the more common. The 2 wings that you kind of push down. You push it down real tight, and then when you go to pull, it won't come off. Does that make sense? It kind of clips into place, okay? When I put it in, I don't know if you noticed, it kind of goes in at an angle, and then you twist as you go down, okay? Sound good? So, that's how you replace the inner cannula. You guys, what you're gonna do is, again, while this thing is on, you're gonna take the gauze out, you're gonna clean with some scrubby stuff, you're gonna put a new gauze in, you're gonna take the ties off, put the new ties on. Remember, you don't untie both sides at the same time, because then it could theoretically just fall out. I mean, they don't do that, they don't just go, but, you know, it could, maybe somewhere, all right?
And in Cook's world.
In NCLEX world, you know. Just assume that everybody's trying to rip this thing out every time they can, okay? What else? You want to know what size. You want to make sure that you know that you have a replacement available at all times, that you have an obturator so that you can actually put it into place. You do want to check if it's supposed to be cuffed and the cuff is supposed to be inflated, then you want to make sure that you're checking that it's inflated, because they do get holes in the balloons, they get holes in the cuff, they get the tubing torn all the time, okay? We good?
You never talked about when to like pre-oxygenate or hyperoxygenate.
Yes, we're gonna go over that right now.
So you take out the inner cannula, then you suction, replace it.
No. So the only time we take out the inner cannula is when we're doing care and cleaning. You take this out. Notice that I only touch here. I don't touch this sterile piece right here. Okay. I would, in the real setting, throw this away. For your care and cleaning, you have a kit that you're going to take the little pipette, you're going to clean out the inside of it, you're going to set it in one, rinse it off, set it in the other with the water, rinse it off, and you're going to put it back, okay?
But we would never do that in the hospital, just in here.
Don't say you
That's
have
work for the VA.
You're probably not ever going to do it in your career, but there is the potential that it may come up. We had taken this skill completely out of your skills checkoffs, and then somebody at one of our advisory meetings was like, yeah, nurses still need to know how to do that. So we're like, okay, let's work it back in to make sure that you guys are at least familiar with it, okay? The truth is do not accept a patient with a trach if you are not properly trained and prepared to take care of a patient with a trach. Make sense? Okay. Some of you might go to home health right after graduation, and then you get stuck with like a chronic kid that has a trach, and you're like, I don't really know much about trachs. Make sure that they train you about how to take care of that kid's trach. Cool. Because they will get pneumonia. All right. So again, if I wanted to put this
When you
in,
need to.
When you
everybody's
do.
got more moisture than mannequins do.
The care is after the suction.
Come on.
You're not good at suction. You suction the
Alright. So, again, when you put this in, you don't touch here, you touch here. Go sideways, twist, push down, make sure it clicks, make sure it's in place. Okay, so don't cover their nose and mouth while you're doing it. Right? I'm gonna raise the head of the bed up, which is right here. Alright, so we're gonna pretend like they got the trach ties on. Yeah?
So this is a new patient you're walking in on.
There's a new patient we're walking in on. They got the trach ties on to hold it in place. There's a gauze, all that good stuff. Feel good? I'm just gonna show you the suction piece. I'm coming in because I'm hearing coughing and hacking. They're desatting on the monitor, right? I'm like, oh, I need to go check them out. You know, hey, my name is Justin. I'm here to make sure you're doing okay. And they're like, I'm going to go ahead and suction your trach. Is that okay? Now, just because they can't talk doesn't mean they can't communicate. So they can nod, yes, no. You know, I'm going to go ahead and suction you out. And they're like, no, I'm going to go ahead and do it anyway. You know, no, you know, patients can refuse care. So don't do things that they say no to. But you make sure that you got a replacement trach, you make sure that it's secure, you make sure the cuff is here, all that good stuff, okay? Now, usually, hopefully, they're going to have on a trach collar. Something like this. Why?
Sorry, we can't see.
Well, they're breathing through the tube. What do we have the trach collar for? To nebulize it, to give it a little bit of moisture, humidify it. That makes sense? So if we have dry room air, what's going to happen to the mucus?
It's gonna get dry and
What's it going to do?
clog up.
Clog it up, right? And so we want to make sure that it's staying humidified to keep it nice and moist and thin and they can cough that crap out of it. Sound good?
Mm-hmm.
Okay, so they should have a trach collar on. Not everybody does, but they should. Okay. Every room should also have an ambu bag set up and ready to go. Okay, you've seen ambu bags. This one does not have the mouthpiece, nose mouthpiece, right? And that's because it connects directly onto here. Oh, sits right on. Cool? Okay, when you go to rip it off, you don't rip it off, right? You're gonna hold down on the neck plate, the flange right here, and pull off. Does that make sense?
Mm-hmm.
The way I'm not pulling on the cuff. We good? Okay. All right. Hopefully your ambu bag doesn't come disconnected, but what would we like to set the oxygen at on the ambu bag?
Pretty high.
3?
Kind of like a non-rebreather.
The lowest?
No.
2, 3, 4? Hold on, let's listen to it real quick.
Until it's inflated.
This is to
They don't have
save
a
your
bag.
life, right? It's like the most that we can do for you.
15.
You guys tell me when.
15.
You know what I do? 15?
15.
I agree. Lots of flow. All oxygen, 100% oxygen. Okay? Alright. So, this person is in distress. They cannot breathe, right? I'm coming in to do an intervention. So we're not starting at SATs of 100%. We're starting at SATs of like 87, 88. Does that make sense? I'm going to shove a tube into their airway and suck stuff out for like 10, 15 seconds. Are their SATs going to go up or down while I'm doing that?
Down.
Okay, so do I want to start at 87, 88?
No.
I want to get it as high as I can beforehand, right? So again, I've identified the person, I've gotten all my supplies, I'm ready to go with everything.
Have you already put your sterile gloves on?
Got my sterile gloves ready, okay? You can put them on, it just kind of depends. But, let me steal the table.
No.
Go for it.
And then the kit that I walked in with.
Oh, so sorry.
You okay? You running into people?
With this one?
Oh, you guys another kit. Is that it?
It's right there.
It's all open and torn apart. There we go. Perfect. It's exactly not sterile. Just like you want. Okay.
5-second rule.
5-second rule. All right. So. Knock, knock, knock. Yeah, if you fall down, I didn't see anything. Knock, knock, knock. Hey, this is Justin. Come to check on you. Looks like you're not doing too good. Oh, your stats are 87%. Can you give me a suction? This is Miss Jones, right? I mean, I don't really know why you identify the patient. Obviously, if they're in distress, please rescue them. I don't care if it's your patient or not. But We're gonna say that you identify the patient because it's part of the 6 rights thing, right? Okay, this is Ms. Jones. Yes, you were born January 13th, 19. Who cares? Okay, your stats are 87%. We need to do something about this, so I'm gonna go ahead and get my kit. I make sure that I got my replacement trach, my operator, just in case we have too much fun and we rip it out. Okay. In here, I go ahead and I pop this open. Will you fill this up with water? Marlo's like, no. Will you help me out?
Did she really say no?
No.
No, I should have a handful. I picked the wrong person. So it's just, yes, motion activated.
Is it okay if I get this?
Yeah, that's fine. You gotta say Shazam. There you go. Perfect.
I don't think she's too young for that.
All right, thank you. So what I had was in my room, I had sterile water. Okay. If it is open, how long is it good for?
24 hours?
24 hours. So every bottle of sterile water should either be closed, not opened, right, or should be dated with somebody's initials. And when you look at it, when you come in at the beginning of your shift, you should check to make sure it's not ordered in 24 hours. Okay, because stuff grows, right? Usually when you're on day shift, you know you're gonna bring a new bottle in. Does that make sense? Okay. So I brought my bottle in. It's good. I went ahead and I dumped it. Right, so I'm good here. Cool. Okay. I have my gloves and my suction catheter. And you're gonna say, when do I put on my sterile gloves? Well, I'm gonna designate one hand as dirty and one hand as sterile throughout the whole time. I want to make sure that I got my suction up, that it's turned on, that it's set to continuous. You set this to continuous because you're controlling it. If I set it to intermittent, I'm setting this machine up, it does its own thing, I can walk away. So like an NG tube, right? But I'm going to be in here actually controlling the suction. All right, so you don't always want to touch stuff without gloves on, right? Because it's got lots of nastiness. So just some regular clean old gloves, okay? Because you're touching the end of it. We're gonna pretend like this is connected to here and this is connected to here, but I don't have another tube, so I'm just gonna do this for now. All right, so I check it and I got it. Cool. What am I shooting for?
80 to 120.
80 to 120, right? So there's 100, another one little bar, and 120. Cool. If it was too much, go up or down. Okay? Not that number, but when it's actually included. You could also kink over the tube and get the same effect without touching the end if you wanted to. Alright. So my suction is good. Are we good here? We have our ambu bag, it's turned on to 15, we have our suction, it's set up. We're good? Everybody okay? Alright. So probably want to leave this on right until the last second because it does sometimes have oxygen. Not always. A lot of times it's set at room air and it's just doing humidity, but sometimes it is set up to oxygen. And you would see it if you connect it over here to your oxygen. Okay? You do want to be aware of what baseline amount of oxygen your patient is on. Alright. So, come over here, I say, I'm going to go ahead and suction them. I've identified them. I checked them. I listened. I said, yeah, you know what? They need to be suctioned. Their stats are bad. I got all my equipment set up. Tore my gloves, I go get another pair. Good stuff.
So at this
if you
point,
guys
you
have big hands, tell us, we'll get you another pair of gloves.
But if you have really small hands.
We have other gloves as well. Less of a problem.
so at this point you would have already given them the oxygen to get their stats stable.
No, not yet. Depending on what's going on. I walk in and their stats are 67 and they're blue, I'm gonna bag them, right? If I walk in and they're 87, 88, I got a little bit of time. Make sense? You have to look at the patient. Okay? Alright, so gloves on, take my catheter, set it on top of where my sterile gloves were. That's all sterile, I can use that as a field. Cool? Usually, you're going to go ahead and bring everything to right here, okay? But I don't want to turn my body on you guys. Alright, so, I'm going to go ahead. This is going to be my dirty hand. That make sense? Okay? So I'm going to pull this down. I'm going to take this. Now, work smarter, not harder. Miss Jones is comfortable, but she can't breathe. I'm going to move the pillow. I'm going to go ahead and put the ambu bag on. I'm going to give a nice little deep breath. Nice and slow, right? Nice and slow. And so while I'm giving her breath, she can breathe. While she's breathing, you'll feel a lot of resistance. Like if she tries to blow out and you try to push in, it's going to go, you know? So you just wait. And when she goes, that's when you give the breath, right? And you're just helping it out, okay? So I give her a couple of breaths, get her sats up. You can go for like a minute if you want to, but it's one breath every 5 to 6 seconds, nice and slowly, over a second, nice and relaxed. Not trying to squeeze the whole bag, not trying to do all this crap. Make sense? We're good? Okay. All right, so from there, I'm gonna go ahead and take it off. Holding down on the neck plate, pull down, pick up the suction, connect it. Okay, now I got a little bit of time, but I don't want to wait for 15 minutes, okay? All right, so no suction, suction. I don't want to suck it because it's not connected to the canister, but I would hold down, got water in there. That makes sense? I'm gonna come over here, all right, and straight in, about 10, and then I'm down, right? Thumb was up the whole time while I was going down. Now I'm gonna go ahead and intermittently, as I pull up. Sound good? And then suck the water to clear the line. Now, I can still hold this like this. I can give her a couple more breaths if I need to. Alright, Miss Jones, we're doing okay? How many seconds one more time? Okay, we'll do it one more time, okay? Let's see how you're doing. So I'm gonna hold down on the neck plate, move, pull down, go in, no suction, half a centimeter pass, which is about 10 centimeters. Good. I'm gonna go ahead and pull this up for a second, come back over here, clear my line. I'm pretty good with that, I'm happy, so I'm gonna go here. I'm gonna watch her. If she's coming up, that's good, I'll leave her alone. If she's not, I can give her a couple breaths and bring her up. Good? Happy? Okay. As a reminder, when I'm putting this catheter in, okay, I want to get it about here, right? In case there's gunk on the end. I'm not trying to do this. See what I'm saying? So if I come back to here, it's about 11. I was saying 10, 11. Now, this is a 6. They have XLT, like where it's extra long. Those will be a little bit longer. You gotta go a little bit deeper. But again, if you're going until you meet resistance, you're going too far. Sound good? Okay. An ET tube, same thing with the ET tube. You're going to the end of the catheter. An ET tube is supposed to be 2 to 3 centimeters off the cariner. So if you're hitting resistance, look at how deep you were. Next time, go a centimeter or 2 less. You good? Any questions? All right. Let's split up. Inside the table, you're gonna find those supplies. I'm gonna make my way around. Make sure that the room's all set up.